Well, it is a great privilege to be here. I work over there, which is a little distance away, and despite the distance being quite small, the interactions are not as robust as I think they really ought to be. And it's a pleasure that we're beginning to see more people and doing a little bit more testing that's coming from here. And I think that that's all to the benefit of our common patient population, and I hope that we can continue that. That's part of the reason for being here. But the main reason is to convince you that the really important images are here, and that, although beautiful, is something you can see at other times. So, we're always faced with the idea of when do you study people, when is genetics important, when does it become a consideration? And the answer is that, as a rule, the younger the person in whom an aneurysm or a dissection is defined, the more likely it is that there's an identifiable genetic cause. If you add in family history of either aneurysm or dissection, that actually ups the ante and makes it even more likely. Is genetics an equal opportunity player, regardless of where you are in the aorta? You will have seen this slide just a couple of minutes ago because I filched it from the same place that we had it before. So for this, in the ascending aorta with type A dissections, there's strong heritability, and there are many genes that have been involved. Almost, we're now up to more than a couple of dozen genes that are involved. In the descending aorta, so type B dissections, which start after the subclavian, it's clearly heritable, but there are a few genes that are known, and you have to be careful that you're not trapped in calling it a type B when it's actually a type A that goes around and comes down through, through the arch. So there are a few genes. In the abdominal aorta, down in this region, it's clearly heritable. So if you look at families, about 15% of first-degree relatives will have an abdominal aorta. That's work that actually started with Kai Johansson and also came from Yale, now probably 3 decades ago, I think, here. But we have very few genes where we can say, yes, this is the genetic component that actually makes a difference in this area. So we really concentrate in terms of genetics on those conditions which involve the ascending aorta or the ascending aorta and the descending aorta in an extended type A dissection. So when we first started getting into this, every young person with an aortic aneurysm had Marfan syndrome. And I think you'll remember back to that. And this is basically how it was translated. It was a little different. So cardiologists tended to say, well, he really has or she really has Marfan syndrome. But at the surgical table, most people who were young and had aortic dissections, especially if they were tall, had Marfan syndrome. And then bicuspid valves were found to be associated with aortic syndrome, and this became part of the form Frust of Marfan syndrome. That is, not quite Marfan syndrome because they didn't have many of the other features. That is, if you look at this guy, he's tall. You can see his long fingers, which is arachnodactyly or spider fingers. The couple of days after Halloween, I guess that's an appropriate thing to introduce here. You recognize he's wearing glasses, and he has lens dislocation. So if you are a cardiologist, you'd like to look for those kinds of things. Looking for lens dislocation is actually very simple. You can do it in the room, and all you need is to use a pen light or an otoscope and light the eye from the side, have the person look back and forth, and you can see the lens shimmer. And if you want to practice on people who've had their lenses replaced for cataracts, because you also get the same kind of shimmer, and you'll see it there. So that's a clinical way. So that's how you can see the genes that are involved, by a very simple examination, and ask about family history. So in the middle of the last decade, around 2004, 2005, it was recognized that there were people who had aortic aneurysms. They looked like they might have Marfan syndrome, but by that time it was possible to test for mutations in fibrillin-1, which is the gene that has mutations in people with Marfan syndrome, and not find them. And so at this point, the search began. And it began looking for candidate genes, or in some cases, a little bit after this, by actually looking at all the genes, by looking at families, and beginning to identify genes that could be involved. And so this condition, you'll see, became known as Lowease-Dietz syndrome. It probably really ought to be called Mizoguchi-Boileau, because about a few months before this, the Japanese group and French group combined to find one of the genes that's involved. So rather than fibrillin, these genes involve the transforming growth factor beta receptor genes on the cell surfaces. And they have some characteristic findings. If you look here, how many of you look in the patient's mouth when you examine them? Okay? How many of you look at a uvula? You all know what a uvula is. You spend a lot of time studying it. You open your mouth and you look down there and you say, is my uvula in good shape today? And you say, yes, I only have one. But the real key to, you don't need this. You really are looking here. I know that, right? But it makes it lighter and easier to see. But what you see in a number of these people is a bifid uvula. That is, people who have two. Or it can be more subtle, or here's it's more complex, or it can be split, and hard to see because the two sides of it are sit together. But this is a key aspect of making a diagnosis. They often have, their eyes are a little bit far apart. They may have cranial abnormalities in the skull, and they can have quite wandering vessels. Their aorta can be quite tortuous. So these were the first two genes. They were discovered in part because fibrillin is a storage vat for TGF-beta molecules. And when the fibrillin is abnormal, there's excess production, and so this is what it interacts with. And so they were looked at as candidates. SMAD3 is another gene. When these people were identified, again, they came out of the same pool. They looked like they might have Marfan syndrome. They were often tall. They had aneurysms and dissections. But one of the key aspects there is that some of them had a bifid uvula. And here you can see it's split down the middle, but not really two. And they also had osteoarthritis. So this became known as osteoarthritis aortic aneurysm syndrome. It's become clear that many of the people who have mutations in this gene don't have osteoarthritis. TGF-beta 2, so one of the active components of TGF-beta mutations the same. The clinical pictures look similar, although the striking thing is for many of these people is that you can't tell. They actually don't look particularly unusual. And it's one of the real surprises and one of the things that leads to how do you go about doing the testing and how do you evaluate. Arterial tortuosity syndrome, all the previous ones are dominantly inherited, so one copy of the gene is involved, and you may see it in multiple generations in the family. This is a recessively inherited disease, so each parent, in this case here and here, are carriers. And what you see is this very marked arterial tortuosity in the neck vessels here that you can see. They're just going back and forth. And so if you measure the length from here to there by essentially stretching the vessel out and measuring the length, it'll be half again as long as the normal. But it's marked by seeing this incredible tortuosity. Here's the mom, she doesn't have it. Here's the dad, he doesn't have it. And here's the unaffected sibling who doesn't have the same thing. Type 3 avascular Ehlers-Danlos syndrome is another rare condition. Most of these are much less common than Marfan syndrome. We think this affects perhaps between 1 in 20 and 1 in 50,000 people in the population. This young man I actually first saw here in 1976, I think, because he'd had a dissection of his right subclavian. Here are his two daughters. She is affected. She died a couple of years ago, his unaffected daughter. Here's a population of people in Denmark. Here's a family that we saw here in which the daughter and the dad are affected. They have a much milder form, so that their survival down here is like this compared to the survival of people who have these mutations with a median survival of about 50. So very serious, and this is dominantly inherited. And aneurysms can occur almost anywhere. The head is omitted, but there are aneurysms in the head as well. They have thin skin. They bruise very easily. Pat Ryan had experience with surgical intervention in one of these people recently, and sometimes it can be dicey. ACTA2 is another gene that's involved, and one of the features in this is fixed livido-reticularis. So you all get livido-reticularis. It's that lacy appearance of your arms when you get cold, and it looks as if you're wearing a little, you have tattoos on your arms. That's transient. It goes away when you get warm, but when it's, in this case, it's often fixed, and you have this lacy appearance here. So this changes, and now we're looking at, these are genes that are involved in the smooth muscle cells that are in that part of the wall that you heard about of the media. Myosin heavy chain 11 is another one. That's also the myosin, the contractile elements in the smooth muscle cell. And one of the complications with that is the, which I think is here, is the retention of the, oh God, help me out here. The connection between the pulmonary artery and the aorta. That's, yeah, it's a ligamentous arteriosa, but it's still intact at that point. So if you see that, think about this gene. Notch1 is a gene that's involved and is initially described because of bicuspid aortic valves. So here, an often calcified, and usually, but we're recognizing as we're seeing more of this that there are people who don't have the severe calcification. Here it occurred in these two families with early calcification in the late teens or early 20s requiring surgical intervention. So what we see is a whole series of genes, some of which involve signaling molecules that are out here, receptors for those signaling, the genes that are involved, or the proteins that are involved in transducing these signals from the receptor into the nucleus and activating genes. And so you can see here there are matrix genes by glycan, type 1 collagen, type 3 collagen, fibrillins, lysyl oxidase, which cross-links molecules, and some others. Here you see the signaling genes, the contractile proteins that are involved, transport proteins. This is a copper transport protein, and this is probably an ascorbate transporter. And then protein-modifying genes that are inside the cell. So this whole range of things is found almost exclusively, the major part is in the ascending aorta aneurysms, although many of them, and particularly the genes that are involved in matrix and in signaling, can have involvement of the smaller arteries throughout. And so it's one of the key issues about why is it important to look at these. So when we were in medical school, when I was in medical school, and I think when Glenn was in medical school, it was very clear that the key to diagnosis is a complete history of the present illness and comprehensive physical examination. And that in that, the most important part is the history. That we were taught that if you take a good history, 95% of the time you'll get there and the physical examination gets you the rest. So echocardiography, MR imaging have become very important tools, but DNA sequencing now has become an added component to it. And we have all of these genes that are involved here, you can see. And for the most part, I cannot tell the difference. I mean, these are people I'm used to seeing, and I can't tell what gene is involved or how to do it. And so we've really moved from the idea, it doesn't matter how good we are in terms of the history and the comprehensive examination. The overlap among these conditions is so great that we really can't tell until we sequence a gene. So, and the genetic studies provide precise information at relatively low cost. They're cheaper than a CT, they're cheaper than an MRI. And we get, just as you are, you're able to screen, large numbers of structures in here with echoes or with CTs, we are able to screen a large number of genes at the same time. So why do we test? Well, specific diagnosis with implications for care. The care for people with Marfan syndrome is different than the care for people with vascular Ehlers-Danlos syndrome, and is often different for the others. For Marfan syndrome, well-established guidelines have been established with usually ascending aortic replacement at about 50 millimeters. For some of these other ones, replacement is recommended at below that because there's a risk for aortic dissection in the mid-40s, and sometimes even with a normal-sized aorta. And for vascular EDS, there's a lot of concern about intervention because of tissue friability. The second thing is identification of other affected family members. So for us, as geneticists, the family is our patient, and which is a little bit different than what often happens with you. You may get a history of involvement, but you're much more likely to see the patient who's sitting in front of you than to go out and recruit the family. And our job as geneticists is really to go out and recruit the family, because with dominantly inherited conditions, if it's the first affected person, the children of that person have a 50% risk of receiving the altered copy of the gene and therefore of becoming involved. If there's a family history, then it means that there may be collateral relatives, and you may be looking at a large family where there's a risk. And then the final thing is family planning and risk assessment. So risk assessment, 50%. Once we've identified something in the family, we can actually just test for that specific thing. And the cost goes from $1,500 to do the genetic testing to a couple of $100 to do the specific site-specific testing. So it really makes a difference, and it makes it easy to look. So here's a long list of genes. You're not expected to read that. Or even, there's not even going to be a quiz on this either, so you don't have to memorize it for that. But how do you deal with things, and what do you do? And when we did this previously, the technology was not efficient enough. We had to tier it with the most likely and then go from there. I'm sorry, these are out of order. This is really a matter of some of the things that you have, the implications for care. So that for Marfan syndrome, yearly or more frequent echocardiographic studies, and a couple of times looking at the more distal part, particularly if there's been aortic replacement, and particular kinds of surgery. For Lowease Dietz, extend the imaging beyond the aorta to the side branches and other kinds of treatment. For vascular EDS, the benefit of systemic arterial tree imaging is controversial, and probably treatment is important, although we're a little uncertain about that. So technology is changing rapidly, and the type of testing and the number of genes studied will evolve quickly. So we would start with one gene usually. Now we can, for the cost of what it used to do one gene, we can probably do all 20,000 genes at the same cost, if we want to. Now that makes the analysis a little bit more complicated. But so the costs have declined from about 7,000 or so for a full panel, which would be 20 or 30 genes, now to closer to between 500 and 1,500 with next generation sequencing. Whole exomes will be cheaper and easier in the near future, and we will be approaching these costs for whole exomes. They're now $1,500 to a couple of $1,000 clinically. And it may be that we get to the point of doing whole genomes for the same cost. And the advantage of doing that is that it allows us to take the data where we didn't find something and go back and reanalyze everything that's there. So thinking and decision-making are expensive. Your time is much more expensive than it is for the technology. Technology is relatively cheap, and so our approach to this is basically do it once and do it all. That is, don't even worry about what genes you're ordering. You might want to say, well, this person probably has Marfan syndrome, and so we're really looking at fibrillin. But if you ask us to do the testing, we're going to do all the genes anyway, because that's just how the technology works. It's much easier for us to do that. And if we find something in one of the other places, we'll tell you. I mean, that's the part of good medicine. And so we will look at all the genes that are involved here. So, what does a genetic report look like? And how many of you have ever read a genetic report? Does it ever make any sense? So we have 2 people in the room who've seen it. How many of you have ever tested people in your populations for genetic conditions? A few. Good. That's great. I'm glad to hear it. Why don't you? That's a rhetorical question. And there are a number of reasons that people don't. One is the perception that it doesn't make a difference for clinical care. And the second is that it's very expensive, which And the third is that you don't know what you get if you look at a report. You have no idea, you're not quite sure. And there are all of these terms of variant uncertain significance, which means, it reminds me of The Princess Bride, where they're going through that area of the rodents of uncertain size or whatever it is. I mean, that's what a variant of uncertain significance looks like to me. But we actually divide things where we know what the mutation, that we know it's a mutation, we call it a pathogenic variant. Or we know that it's like those findings that you just saw on CT, that it's a benign variant, which means it doesn't contribute to the clinical picture that you're seeing in front of you. And there are these other ones where we're not quite sure. Sometimes where we truly don't know, and others where we think it's probably the one, and the other ones where we think it's probably uncertain. So those are things that are uncertain in what you see. This is what a report looks like. You get the idea of where the sample came from, why things were tested, what the indications for testing were, and then what the result is, a call 3A1 pathogenic variant identified. And here's how the name of it looks like. So this is the nucleotide change. This is the predicted protein change, what kind of effect it is, and then a description of what the clinical effect is. That's what you should be looking for. What you also want is you don't want to have to do this by yourself, because you will be confused by it, and you need to have somebody either in the laboratory or locally that you can talk to, and that makes sense. And it gives you and it gives your families much better ideas about what's going on and what's important. So how can we listen to our DNA test? How can we use this information? You can see that it's very important in terms of understanding natural history, understanding what the complications are likely to be, and also in predicting when and what you should do. So do it once, do it all, test. Be a good geneticist.